So these are the things that ARDMS wants for the second trimester. You want to assess the shape of the fetal head at the level of the biparietal diameter. Look for the thalmi, that's one of your main landmarks. You're going to measure the biparietal diameter, the head circumference. Look at the cephalic index, which is the ratio of the BPD to the OFD. Look at the cerebellum in the posterior fossa, looking at the orbital distances, both inner and outer, assessing the abdominal circumference, the femur length, humerus length, radius ulna, and then any other bones if you're suspecting a problem with the long bones. So fetal age, the first trimester, your mean sac and crown rump length, especially if you can see a crown rump length, those are the most accurate for determining the correct gestational age. So once that gestational age is established, make sure you do not change it, because otherwise you just have a change in due dates. In the second trimester, it's these 4 measurements, the BPD, head circumference, abdominal circumference, and femur length, that is going to be giving us the best estimate of the baby's age. But as we get further into the gestation, the less accurate ultrasound is for dating purposes. All right, so the BPD, the biparietal diameter, when we get established that plane, that axial plane, we'll be measuring the head from side to side and then putting a little tape measure around the baby's head. And this is at the transthalamic plane. And we're going to measure it where we can see a little bit of the thalmi, the third ventricle, cavum septum, and the cavum septum pellucidum interrupts the falx. So this is the plane where you do see interruption of the falx by the cavum septum. The calvaria should be seen. They should be smooth and symmetrical, and it should be more of an oval shape. You do not want to see a round shaped head. So sometimes once you get into that plane, it's just little minor adjustments, just tilting your transducer up and down. And again, cavum septum should interrupt the falx. So those are your main criteria that you're looking for. So if we're looking at this diagram just from anterior to posterior, we see the falx, interruption of the falx by the cavum septum, continuation of the falx. And right at this plane, this is where you're going to see the thalmi, and this is how you're going to do your measurements. The first measurement is from the outside of the near wall and then to the inside. So this is one of your only measurements that you're going to measure from the outside to the inside. So the outside of the nearest portion of the skull that's closest to the transducer, and then the inside. And when you're looking at all these measurements, you do not include skin line, you're just including the skull. So nice oval shape to the head, and you're measuring the distance from the outside to the inside. And if you think about it, when you're going through, when you're first looking, you just want to try to make sure that they're even on each side. And if you think about it, when you're doing your measurement, you get halfway, you get to the other side, it should be double what you had when you were at the falx. Just a quick way to kind of make sure that you're in the proper plane. So doing the head circumference, again, it's at the same plane, that transthalamic plane. And now we're just going to put a tape measure all the way around the baby's head, not including the skin line, but just looking at the skull. So looking at, this is the falx, cavum septum pellucidum, this is the extension of the falx, and then these are the thalmi on either side. So right through the middle of the brain. And if the baby's head's turned to the side a little bit, you just want to make sure that you're when you're doing your measurements that you're perpendicular to that falx. Okay, the cavum septum must be visible, or the columns of the fornix when you're doing your measurements. Either one is acceptable for measurements by AIUM guidelines. And calipers, again, not including the scalp thickness. So anterior to posterior and near side to far side. And now this measurement's always on the outside of the skull all the way around. Okay, so pitfalls, don't confuse the cavum septum with the columns of the fornix. It's okay to get your measurement there, but if you do that, you need a separate image demonstrating that you do see cavum septum pellucidum, because that really is a clue to a lot of different abnormalities within the brain. So if we're looking at the head, this is cavum here, separating the falx. Here you see the 3 lines. So that's just slightly below the cavum septum pellucidum, okay? And that's called the columns of the fornix. So it's okay to do your measurement there, but then you have to have a separate image to document that you see the cavum septum pellucidum. The columns of the fornix are just paired nerve columns located just inferior to the cavum septum. So if you see right here, here's the cavum septum pellucidum. Corpus callosum lives on top of that. So these are just below the cavum septum. So just be aware, just a little bit of a technical thing. You need to make sure that you are definitely seeing the cavum septum. So if you see the 3-line sign instead of the true interruption, a hypoechoic space interrupting the falx, then that's the columns of the fornix and not the cavum septum. All right, so the other thing that our ARDMS wants us to assess is the shape of the fetal head at the level of the biparietal diameter and assess the cephalic index. The cephalic index is a ratio to evaluate the shape of the head. So we're going to take the BPD divided by the OFD times 100. And your machines automatically usually calculate this. We're just showing you that formula, so in case they show that to you, you know what it's for. Okay. So we're looking at these different things. Why is that important? Because sometimes, like especially if the baby's breech in the late second trimester and third trimester, you can have more of a dolichocephalic head shape just because the uterus is kind of compressing that head a little bit. Just make sure that there's different shapes, and also with brachycephaly, more of a round shape head, that can be our first clue that there's some type of aneuploidy or different syndrome going on with this child. So really do pay attention to the shape of the head. Okay, why is it important to look at the cephalic index? Well, because there's different conditions that can be found in an abnormal cephalic index. So with dolichocephaly, it can be associated with oligohydramnios because that fluid is distending the uterus, not pushing down on the baby. So if the baby has less fluid, then that head is more likely to be compressed. Multiple gestations because of the fetal crowding, and then late gestational age and or breech. And then brachycephaly, so trisomy 21, hydrocephalus. Some of your strawberry-shaped heads go along with 13 and 18, so really do pay attention to not just the head size, but then looking at the shape. So this would be a brachycephalic head. This is dolichocephalic, and then there's a nice normal in between. So when we're looking at the next thing is we're going from the head, we're going to move down into the abdomen. This is our next major measurement. A cross-section of the abdomen. We want to see only one rib on either side here. We don't want to see multiple ribs because then we're off to the side. And we want to see that the umbilical vein doesn't come all the way to the anterior chest wall. If you see that, then your transducer is actually pointed a little bit more inferiorly. You want to have that nice little umbilical vein dumping into the portal sinus, and then you want to be able to see the stomach. And now this is another measurement that we're going to be doing, the circumference. And again, it's done on the skin layer, not on the inside, but on the outside of the skin layer. So it's taking the location to reflect liver size. Ribs should be symmetrical. Don't compress the abdomen. You can actually make the abdomen smaller if you're pressing too hard. So sometimes you have to remind yourself, especially in the late second trimester and third trimester, to release some of that pressure and allow that nice little abdomen. Sometimes if the baby's spine up or spine straight down, it's hard to get a good AC. If you can get it from the side, that's a little bit better. So either roll your mom or wait for the baby to move, go do another measurement and come back to it. So this is what a nice abdominal circumference should look like. So you can see the ossification centers around the spine, and then that nice measurement all the way. So there's our stomach. This is anterior to posterior, and there's that little J-hook, the umbilical vein going into the portal sinus. So some of these poor places to take the AC, look out here, either from compression or this one is actually a little contraction. See how it kind of distorts the abdomen? And again, with that spine up, kidneys up, it's hard to get a nice tracing on that. And then this one you can see it's oblique because look, we've got the umbilical vein coming all the way to the anterior abdominal wall. So we know that we are off axis. So just kind of pay attention to those little technical tips. And looking at the femur length, we're looking at the long axis of the femur. So we can see a little bit of the epiphysis here, and what we're looking for is just the diaphysis, so the length of the bone here. And when you get that measurement, you want your transducer as perpendicular to that bone as you can. So you should see some nice little shadowing behind it. If it's off angle or you don't see the skin line, then you don't have a good measurement for your femur length. So again, just adjusting your transducer a little bit or tilting it up and down to try to get this nice skin line above the femur length and then the little shadowing behind. And we're measuring for the diaphysis, the long bone there. We don't want to measure the cartilage ends. So the diaphysis, again, is just that center of the bone, not the epiphysis on either end or the cartilage. These are little, if you look at them, if you use higher resolution using a 9.2 or a 9.4, you can see the cartilage of the femoral head there, but we're actually measuring just the diaphysis. Okay? Measuring the humerus length, again, this is one of the other things that we can look at, especially if you're doing that first survey at about 18 to 20 weeks, because we have found that the humerus length is actually a little bit more sensitive for picking up babies with Down syndrome. It tends to be the one that is a little bit shorter. And anytime you think there's a skeletal dysplasia, then you're going to measure all the long bones because these bones are measuring way below the first percentile. We don't routinely measure tib, fib, radius, ulna. It's just if you're suspecting some type of abnormality with the long bones. We do also include looking at the foot if there's an issue, because the femur and the foot, when we're looking at that, the femur-foot ratio should almost be 1 at this time. The foot grows at about the same rate at the femur length all the way up until about 28, 29 weeks. Other things that you can look at is the clavicle. But again, these are only for very specific abnormalities or if you're suspecting a problem. So the radius ulna, when you're looking at the ulna, just remember that the ulna is the longer of the two, and the radius on the thumb side, because think of radial pulse. It's on the thumb side is the radius. But this is the image you would want, is from the elbow to the wrist. You see both long bones with neither of them poking through the skin. You want to make sure you have nice skin line on either side. Radius is, again, that thumb side. And then we look down at the tibia fibula. Tibia is the longer of the two. The fibula is on the outside. And looking at the length of that. So from knee to ankle. And we're looking at the posturing of the foot too. Make sure there's no clubbing of the foot. So knee to ankle, and this is going to be your tibia fibula. And then we can look for the extremities. So if you just get that long axis of that bone, so looking from the extremity, just documenting that there are hands. The most common posturing of the hands at this time is little fist in a little boxer's position sitting up in front of the face. So sometimes they open the hands, but not often. So if you can at least count the knuckles to make sure that there's no missing digits or extra digits. But they don't expect you to have the hand perfectly open. I mean, you don't have time to sit there and wait 10 minutes for the baby to open the hands. If you get it, fine, but at least show that from the arm you do see a hand. You don't want to have a child born that has a missing part that you did not see. And then looking at the foot. So the plantar surface of the foot, if you can get it, looking at the digits. So this is the femur, again with that nice shadow and nice skin covering over the bone. So from the femur, then the lower leg, from the knee to the ankle, and then the bottom of the foot. Again, arms in front of the face with the little fist. That's the normal position for these babies in the second trimester, the little boxer's position. And then if you have 3D, I mean, if you're having a problem, it's nice to look at, but again, not a necessity. And then just little arms, just wanted to show you some of those. If you can get the thumb up, we do look at that in some of our genetic syndromes because some of them have adduction where they're pulling the thumb in, or abduction way far away with different genetic syndromes. And this is just showing you how the different things with the putting on the filter, almost all the machines, even the little laptop ultrasound machines have these little color filters that you can put on. So if you use these little chroma maps, they can actually help you to see the bone a little bit better. All right, then looking at the orbits, which is called the binocular distance, or BOD. You want to obtain the image in that coronal or axial view, and it's seen when the head is facing up, and we're looking at a cross section of the orbits here with a little bit of the nasal bridge, and these are actually the lens of the eyes. So the BOD, the binocular diameter, is from the outside to the outside. And this can be helpful when we're looking for facial abnormalities, microphthalmia, looking for too much distance between the orbits and not enough distance. So again, looking at the lens of the eyes, we do look at that. Even if you're not doing the measurement, the good rule of thumb is you should be able to put a third orbit right inside there and it should be nice and equal. The lens we look at, we want to make sure there is actually an eye in the socket. So other measurements that we look at is transcerebellar measurement. So this is from your biparietal diameter. Now you're just tilting the transducer towards the posterior fossa of the baby. So it's not much of a movement, it's just a little tilt of your transducer. So it's again taken in axial plane. We want to look from the lateral edges of the cerebellum here. And this is going to be correlates pretty much with gestational age up until about 24 weeks. The cerebellum in millimeters will correlate to what your gestational age is. So cavum septum should be in view. We're going from anterior to posterior. So cavum, a little bit of the thalmi, cerebral peduncles, this little bit of tentorium, which is separating the cerebrum from the posterior fossa, the cerebellum. These are both cerebellar hemispheres connected by this little band of tissue, which is called the vermis. So this is the plane that you want to be in. And we'll go through that when we go through more of the brain anatomy. All right, and then fetal weight estimation with the AIUM guidelines. Your best guess on the weight. You can have error rates as high as plus or minus 15%, because there's no way to really straighten out the baby, measure the length of the baby, measure the bone density. So even in the best case, we can be off. We want to make sure that we're looking at the highest resolution. So if you do your survey of the uterus and the adnexa with like a 5-1, something for more penetration, but then when you do your measurements, change to a higher frequency transducer, and you're going to be a little bit better at picking up everything. Okay, so this diagram was by one of my good friends, Jill Bython. You probably heard some of her lectures before too. So the ARDMS, these are their tasks for when we're looking at the brain. So we want to assess the posterior fossa, the choroid plexus, which live in the lateral ventricles, assess the size of the lateral ventricles. We want to look or survey through the anatomy of the brain, looking for any abnormalities or variants. If there's large ventricles in the head, we want to know what else we should look at. Looking at babies with abnormalities of the brain, trying to identify what type of abnormality that is. Looking for that cavum septum pellucidum again, and looking for the shape of the cerebellum and the posterior fossa, and we'll go through some of these variants. And then actually assessing the cisterna magna, the size, and then measuring the atrium of the lateral ventricles, and then looking at the distance of the choroid plexus from the lateral ventricle wall. So from that transcerebellar plane, when we're looking at our biparietal diameter, now we're going to just move back up to the transventricular plane. So here we went from the transthalamic to the transcerebellar, where we're looking back by the cerebellum, and now we're taking our transducer and angling back up towards the top of the head. So in this view, we're going to be able to see the falx going all the way across the skull. You won't see the cavum septum at this plane. So it's above the BPD plane, so we can see the falx all the way. And we're going to take our measurement of the lateral ventricle in the posterior part, which is called the posterior horn of the lateral ventricle, or the atrium. And what's nice about this is throughout pregnancy, this should not measure more than 10. And it's going to look more prominent earlier in the pregnancy because the cerebrum is not that developed. So the ventricles are fluid-filled structures. They're going to take whatever space is available to them. So as the cerebrum becomes more developed, then you'll start to see that the lateral ventricles get smaller and smaller in size, unless there's a problem. So lateral ventricle should be taken at the atrium of the lateral ventricle, which is looking at the glomus of the choroid plexus, which is just the end of the choroid plexus in the posterior horn. So this is anterior to posterior, near to far. This is looking at the thalami with a little bit of the third ventricle here. And then here we've got the posterior horn of the lateral ventricle, and right at the end of the choroid plexus, which is housed within the lateral ventricle, this is where we're going to do our measurement. And we can see that we want to be perpendicular to how that ventricle is laying. So atrium, posterior horn of the lateral ventricle, glomus, all of these things are right here in that posterior horn. And remember 10. Within the head, remember everything should be less than 10. Okay, so we're going to measure the distance from the atrial wall to the choroid plexus. Some people use this, some think it's too sensitive, but actually looking at how far away that glomus of the choroid is from the anterior wall of that posterior horn of the lateral ventricle. They're saying if it's more than 3 millimeters, then it's abnormal. But truly, when it's enlarged, you'll see it kind of like dangling choroid plexus, where you see it hanging down. It's really far away. But remember, the basic one that you need to remember is 10. This should not measure more than 10 millimeters for that lateral ventricle throughout gestational age. And we start doing these measurements at about 15 weeks. So some of our definitions for ventriculomegaly and hydrocephalus. Ventriculomegaly is just defined as a dilatation of the lateral ventricles. So the fetal head size may be normal and not enlarged. But with true hydrocephalus, it's when the head size is enlarged because of the enlargement to the lateral ventricles. And usually with true hydrocephalus, you're going to see both lateral ventricles, third ventricles, even fourth ventricle dilated. So it depends upon where the obstruction is. But truly using the term hydrocephalus is when the head size is enlarged along with the enlargement of the lateral ventricles. So if the head size is measuring normal, the better term to use is ventriculomegaly. What is the size of the ventricles? So when we look at ventricular megaly, right again, looking at the area of the glomus where that choroid plexus ends, where it's sitting, this is anterior to posterior. A little bit of the falx here. Here's your anterior horn of the lateral ventricle. There's the posterior horn of the lateral ventricle. And we're going to measure from inside to inside. All these measurements are going to be inside to inside. So if it's greater than 10 millimeters, then that's ventriculomegaly. So hydrocephalus classification, there's going to be communicating or non-communicating. So communicating hydrocephalus is an impairment of the cerebrospinal fluid reabsorption, which normally occurs through the venous system in the ventricles. So this can be caused by infections, hemorrhage, congenital obstructions, something where it's not being reabsorbed properly. So its choroid plexus are producing this cerebrospinal fluid and it's building up. And the more pressure in the ventricle, then the bigger the ventricle gets, the more pressure it's putting on the cerebrum. And then the non-communicating hydrocephalus or obstructive hydrocephalus due to obstruction of flow to the subarachnoid space. And it's usually by external compression or narrowing or a mass lesion. So we talk about Philly's rule. That's if the atrium of the lateral ventricle and the cisterna magna both measure less than or equal to 10, there is a 95% negative predictive value of any cerebral nervous system anomaly. So usually you can tell there's an anomaly of the spine by looking at the head. The head findings are much easier to look at and assess than actually seeing some of these little smaller flat defects to the spine. So really pay close attention to the head. Is the anatomy in the proper place, the proper location? Is it measuring normal for this gestational age? So this one is a case of aqueductal stenosis. I think anybody can see that these ventricles are way too large. Look how thin the cortical mantle is here. Because as those ventricles, if it's obstructed and the choroid plexus is cranking out more and more cerebrospinal fluid, that just gets more and more dilated, putting more and more pressure on the cortical mantle. So this aqueductal stenosis is hydrocephalus caused by narrowing of the aqueductus sylvius. So from the third ventricle and the lateral ventricles, anything above the obstruction is going to become dilated. And Dr. Gaziano is one of my mentors, one of the docs I worked with in Minnesota for a long time. So this is just a diagram, just trying to show again the natural flow of the cerebrospinal fluid. So we can see here the choroid plexus, which are in the lateral ventricles. That's where we see the bulk of it, but there actually is a little bit that comes down into the third ventricle also. Comes down here and usually sits along the roof of the third ventricle. And so these are the lateral ventricles, the anterior horns, the posterior horns. Then from here going over to the foramen of Monroe to the third ventricle. And then this is the Sylvian aqueduct here, which connects from the third to the fourth. And then the fourth down to Magendie and Luschka going down to the spinal cord. But this is the natural flow, the two lateral ventricles, down to the third ventricle, down to the fourth ventricle. So if you get a nice parasag, you can actually see this. And this is the area you're going to see, you know, the cavum septum, the corpus callosum, all of these things right in that midline. So from the midline, you can see the corpus callosum. Go to the side, you'll see one lateral ventricle. Go to the other side, you'll see the opposite lateral ventricle. But this is where you're going to assess that third to fourth ventricle flow. So here, when I was talking about the dangling choroid plexus, look at how big and dilated the posterior horns are. The anterior horns are here, a little bit of the thalmi there, and there's some fenestration through the falx, so we actually have the choroid plexus has dropped from one side over to the other. So this is called your dangling choroid plexus, where it's just kind of sitting there dangling because the severe dilatation, the massive dilatation to the lateral ventricle. So assessing the choroid plexus. So when the baby is looking up at you and you can't get the nice axial views, you can just do this little coronal view. So we're going from anterior to posterior, and we can see the falx all the way down the midline, and the choroid plexus are the bright areas within the lateral ventricles. And we can see them, they should be pretty symmetrical in size. And remember, the earlier you see them in the earlier gestational ages, they'll be larger, just because the cerebrum is not that developed. And the ventricles and the choroid plexus tend to look at, 14, 15 weeks like they're taking up the majority of the head, and that's normal at that time. But when we're scanning at our 18 to 20 week study, when we're doing our anatomy survey, you must look at both of the ventricles and document them so we can see choroid plexus and the lateral ventricles. And the one that's closest to the transducer is always harder to see because you get some of that artifact from the skull. So if you move your transducer one way or the other, up or down a little bit, and then fan back, then you can get this one here. But do take them, most of your things that are two of, like kidneys, choroid plexus, anything like that, put them on a split screen. You can put them side by side because we like to compare them. So we can see both the left and the right choroid plexus. We try not to measure the posterior horn lateral ventricle on the upside ventricle because of the way we have to angle. We always make it a little bit larger than it should be. So when you're measuring the posterior horn of the lateral ventricle, it's the one furthest away from the transducer that you're going to measure. So choroid plexus cyst is the bane of our existence. We used to think any baby with choroid plexus cyst had an anomaly or had aneuploidy or was part of a syndrome, and now with better resolution of the machines over the last 8 to 10 years, we see them all the time. So as if we see this in association with other things or other findings or an abnormal blood test, that's when it starts to raise our suspicion something else is going on. But we've seen about 1 to 2% of all of our second trimester scans, maybe unilateral or bilateral, maybe small or large. We used to measure and count them and everything. You don't need to do that anymore. If they're really huge, start looking for other things. It's, again, seeing these with other things that leads you to think something else is going on. So choroid plexus cysts, though, are soft markers. They are considered a soft marker for fetal aneuploidy, correlation with your maternal serum screening, whether it's, a quad screen, penta, NIPT, whatever you're doing, along with the maternal age. It's what gives us the best clue as to what other studies need to be done, if anything. And then, getting that targeted or detailed study looking at the anatomy. So choroid plexus cysts by itself, the really large ones, and then you can see a little bit of abnormal shape here too. The greatest association, that one finding of large choroid plexus cysts, you start looking for other things that go along with trisomy 18. That's one of the best associations is trisomy 18. But again, those are usually large and they have multiple findings. 80 to 95% of these babies with trisomy 18 have heart defects. So if I see big choroid plexus cysts, I'm going to look at the face and look at the heart, because those are the two things that will help me decide what else is going on. Once in a while, you'll get choroid plexus papilloma. It's just a subtle rounding of the choroid plexus, and then as it grows. Sometimes you'll actually get teratomas in the head too, so it's really hard. It's hard early on to see them. Sometimes you won't see them until the third trimester. But always, anytime you're putting that transducer down, even if you're just looking for a biophysical, you're always going to look at head quickly. You don't have to take any images, but head, make sure there's not any big changes in the head. Heart, make sure that the heart's in the correct position and the rhythm looks good. Just sweeping through that, and then stomach. Those are the things that tend to change over time. Okay, that transcerebellar view again. So from our BPD plane, now we want to see the cavum in view, and we're just tilting posteriorly so we can go from the cavum, keep our cavum septum in view, and then angling posteriorly on the baby's head so we can look at that cerebellum. So we have the cavum septum, and on top of that will be the corpus callosum. And then we're going to continue down right into the middle of the brain, and remember, in the middle of the cerebellum. And the part that connects both hemispheres of the cerebellum is called the vermis. So we want to assess the vermis. And then the cisterna magna is that little space, again, it's filled with cerebral spinal fluid that's seen behind the cerebellum. Right? So what do we need to look at? What are our tasks? We want to assess the posterior fossa. We look with the cavum septum in view. So we see the cavum. We're looking at the thalmi, a little bit of the cerebral peduncles, going from anterior to posterior. A little bit of the tentorium here. Again, it's just an extension of the falx separating the cerebrum from the cerebellum, from the posterior fossa. These are the cerebellar hemispheres, and this little brighter area here, that is going to be the vermis. This fluid-filled space is going to be the cisterna magna, again, filled with cerebral spinal fluid. The other thing you can assess at this age is going to be the nuchal fold, and we'll talk about that in a little bit. But keeping the cavum, I think the biggest thing that I see when I review images is that people are going too low or angling too much and not keeping the cavum in view. You need to keep the cavum in view when you're angling back, especially when you're doing your nuchal fold measurement. A lot of times they'll send it over for enlarged nuchal fold. Well, they're angled too much. I can make every baby's nuchal fold look abnormal if I'm not in the proper plane, just by angling back a little bit more. So we're going to see the cavum, the thalmi. There's the cerebellum again. Let's see just a little subtle increase of echogenicity here, and that's the vermis, which connects both hemispheres of the cerebellum. And then the cisterna magna. And within the cisterna magna, we'll get referrals for this too, that there's a cyst behind the cerebellum in the cisterna magna. And those are just durofolds or septa that can be seen in the cisterna. So you just want to make sure, you know, if you do see this, if you've got it magnified up and you're using a higher resolution transducer, you may see these little things, and this is just going to be the normal septa or durofolds. And the normal range again for the cisterna magna on the low side should be, 2 millimeters, and high side again is 10 millimeters. Imagine that, cavum vergae, 10 millimeters. Anything in the head, 10 millimeters. Okay, so why evaluate the cisterna magna? Well, because with spina bifida, this is one of our best clues that there's a neural tube, open neural tube defect, is we have an obliterated or too small of a cisterna magna, because it's fluid-filled space. So if there's a defect down in the spine, that fluid is leaking out. So what happens to our cisterna magna? All that fluid is leaking out. So now the cerebellum, where it was nice and round, now becomes more banana-shaped because it's being pulled down into the lower part of the skull. Too large or too much cerebral spinal fluid, and then looking at the integrity of that. Is there enough of the vermis there? Is part of the vermis absent? What is the space or the shape of the cerebellum and the vermis? So this one, too small. Look at how that cerebellum is being pulled down because the cerebral spinal fluid is leaking out because there's a neural tube defect. Again, I was telling you that the head findings will tell you, look at my spine. When you see this shape to the cerebellum, you should be looking for that spine. So this is called the banana sign, looking at that cerebellum, because the cisterna magna fluid is leaking out, so the cerebellum gets pulled down. Okay, the other thing you can see with open neural tube defects is this little pinching in or lemon sign to the skull. See a lemon here, so we got cavum here, there's falx, but look at that pinching in there. This again, these are the findings that'll go along with open neural tube defects. So lemon sign to the skull, banana shape to the cerebellum. So cisterna magna too small can be part of the Arnchiari type 2 malformation. You have herniation of the hindbrain through the foramen magna. 100% association with open neural tube defect. And this is important, not so much for the bigger meningomyelocele, it's the smaller ones and the flat defects where there's no sac or anything over there, the ones that we normally would miss. That's why I really paid close attention to that posterior fossa. So we talked about those, and then ventriculomegaly, because if things are being obstructed, then you can get dilated ventricles also. Okay, so the vermis is connecting both hemispheres of the cerebellum. So we're back here by the posterior fossa. It's just a narrow echogenic structure between the two hemispheres. Formation of the vermis begins about the 9th week of gestation. It may not be completed until about 18 weeks. So sometimes you can see where it looks like, oh, maybe I'm missing part of the inferior part of the vermis at that 17, 18 weeks, but after 18 weeks, it should be pretty complete. So looking at the cerebellum again, and then vermis. These are the thalmi, and there's that cavum septum. You need to keep that cavum in view when you're looking at that posterior fossa. So, looking at both of these images, the one on the left here, we're going anterior to posterior, near field to far field. We're coming back here, we're looking at the falx, looking at a little bit of the cerebral peduncles. There's the cerebellum. What do you see here? So you can see how that vermis is gone. So we have this, and look how big this posterior fossa is. So now looking at this cerebellum, there's cisterna magna there. Do you think that cisterna magna is normal? Yeah, just eyeballing it, that looks pretty good. Well, what about this little thing here? That is the normal 4th ventricle. Again, with the higher resolution machines, you're going to see this. The vermis here is intact. This is a part of the 4th ventricle. So don't call that a cyst, because that is normal. All right, this is, you'll see it on the parasagittal, we'll look at it too. So this is abnormal, this is normal. So knowing your normal versus your normal variance. So we'll talk about Dandy-Walker continuum. It used to be known as Dandy-Walker malformation, but there's just so many different parts or components or variations of this. They call it a continuum because there's different things that we're using now. Dandy-Walker malformation, the variant, and then the megacisternal magna. So it's a developmental spectrum of findings consisting of a cystic posterior fossa malformations. So cisterna magna too large. Again, look how we have fourth ventricles here, but then we have no vermis there. So cerebellar vermis is partial or completely absent, and so now it looks like both hemispheres of the cerebellum are pulled apart. There's no glue, there's no structures pulling the two hemispheres together. Fourth ventricle opens into a large cerebrospinal fluid cyst or cystic component, and the vermis is hypoplastic with a variable size, so sometimes you only see a portion of the vermis is there, so sometimes it'll be widely splayed, sometimes it's just a little splayed. So always looking to see what looks normal, what doesn't look normal, and then measuring, describing what you see. So the fourth ventricle communicates with the cisterna magna. It's called a keyhole appearance. So if you think of, look at a little keyhole, that's what it looks like, where you have that keyhole so it connects. So we've got at least a partial agenesis because we're not seeing that nice thick band of tissue connecting both of the rounded parts of the cerebellum. So this is the Dandy-Walker variant, where the other one was more the true cystic dilatation where it's wide open. So and then this one's just a megacisterna magna, so we're seeing both cerebellar hemispheres, but then this measurement is measuring 11. So it's probably just a variant of normal, and with the megacisterna magna, as long as you don't see anything else, it's probably just a variant. Usually they don't even follow them up until after the kids are born. When they're doing their assessments, then they'll go ahead and they'll maybe get a CT, MRI when the kid's older, as long as we don't see anything else on this child. There are a lot of people walking around that probably have megacisterna magna and don't know it. So fourth ventricle is normal, the vermis is normal, the cerebellum is normal. We just have prominent beyond our normal range of that 10 millimeters for the cisterna magna. So again, if isolate it, and that's the key word, if isolate it, nothing else going on, can be usually a variant of normal. Right? So corpus callosum is the largest midline structure of the brain. It begins to develop around the 10th to 11th week of pregnancy. It's got over 200 million nerve fibers that connect both hemispheres of the brain. So this is what's allowing the different segments of the brain to communicate to each other. It transfers and integrates motor, sensory, and cognitive information between the cerebral hemispheres. So it's very, very important. So that's why if we have a partial or complete agenesis of the corpus callosum, there's a wide variety of things that can be going on with this child when they're born. And we don't know. We can have two cases that look completely the same on ultrasound, and one baby do fairly well and the other one do terrible. So it's hard for us to be able to qualify how the baby is going to behave once it's born just by looking at this. But this is just looking at MRI of the brain showing the normal appearance of the corpus callosum, so you can see the different structures. So this is our cavum septum pellucidum here, and then this is the corpus callosum. It's a little band of tissue. So when we're looking with 3D, one of the things we found helpful, 3D is wonderful, it's cute to look, give all those nice little pictures, but for babies, probably the two areas that it really helps us the best is going to be looking for cleft lip, cleft palate, looking for the cavum septum, and looking at the corpus callosum. You get that axial view that we're used to getting for our measurements. You're going to put your point right on the center of the area where the corpus callosum is. You do your sweep, and then you can get to this area where you can see how much of the corpus callosum do I see and how much of the cavum do I see. Because if we see the cavum septum pellucidum here, this is the corpus callosum right on top. So this is probably one of the best areas for 3D in OB. Otherwise, 3D, probably the best thing for OB/GYN is the GYN. It just does phenomenal in GYN, but it really is, it's not that helpful in OB right now. But this area, and then looking at the cleft lip, cleft palates, really is good. So we're going to make our box nice and small, but this is what we can do, is we can assess that area of the cavum and the corpus callosum. So if you're having a hard time looking at the corpus callosum, most machines have 3D on them. You can do that sweep. but just put your dot right in the center of the cavum septum. So why is it important to look at the corpus callosum? Well, because agenesis of the corpus callosum can really impact this child's life. So it can be complete or partial. Most consistent finding is this teardrop-shaped ventricles on the axial view. And that axial view is the view that we get when we're doing our measurements. So something we're very familiar with looking at. So what happens is you have an enlarged posterior horn and very tiny anterior horns. You can have absent cavum septum pellucidum and corpus callosum complex on the coronal view and sagittal views. And what happens is if you don't have a normal corpus callosum there, because again, these are all fluid-filled structures, so if there's no roof, think of the roof on the third ventricle is that corpus callosum. If there's no roof, what happens? Third ventricle can be elevated, high-riding, and more dilated. And then people think it's actually cavum septum when it's not, it's a high-riding third ventricle. So again, it goes back to location, location, location. If it's right in the middle of the brain, it's more likely to be an elevated third ventricle. So we'll look at that. This is just a little diagram from the internet, these teardropped lateral ventricles. So on our axial view, which we're very, very familiar with looking at, usually you have your falx, and you can have the anterior horns of the lateral ventricles here and the posterior ones there. But with this colpocephaly, with this absence of the cavum septum pellucidum and partial ACC, you have the anterior horns are further away from the falx than what the posterior horn is. So that's why they call it teardrop shaped. So think of like a little teardrop. So that's colpocephaly. Because usually A should be closer to the falx than what B is. Because usually your anterior horns are right here, and then the posterior horns are back here. So if you can't see that cavum septum pellucidum, then start looking for what is the shape of my lateral ventricles. Because this will help you. How far away is that anterior horn of the lateral ventricle from the posterior horn? Anterior horn should always be closer to the falx than what the posterior horn is. All right, so complete ACC, this one was at 29 weeks. Can you see how easily somebody can think that this is cavum septum? But look how far back it is. It's in the middle of the brain. It's, you got thalmi on either side. And then we're looking at, this teardrop, a very small anterior horn. And then we have that posterior horn, that teardrop-shaped lateral ventricle that's really close, almost completely right next to the falx. But this is a high-riding third ventricle. Your cavum septum should be up here a little bit more. So things to remember when you're looking at the cavum septum pellucidum and trying to figure out, do I have a presence or is it absent? Is it small? What else is going on? If you visualize it, then you exclude a diagnosis of the ACC. Because with ACC, you're not going to see a normal cavum septum pellucidum. You're going to see a normal corpus callosum if you see a cavum septum pellucidum, at least a partial. If it's not visualized, it includes a lot of different possibilities. So you can have complete AC, you can have hydranencephaly, you can have alobar holoprosencephaly, schizencephaly, porencephaly. There's this whole laundry list of different neural abnormalities that you can have just when that cavum septum is not seen. So really do pay attention to that. Embryologically, the cavum septum is associated with the corpus callosum, and so if there's defects to the cavum septum, it bears in mind that there may be some abnormalities of the corpus callosum. And it's so much easier for us to see the cavum septum than the corpus callosum, so that's why we focus in on that. We're going to move on to the next thing. So hydranencephaly is the complete destruction of the cerebral hemispheres. There's no normal cerebral tissue. It's fluid-filled space because, again, those ventricles, those chorioplexes are producing cerebral spinal fluid. They're going to take up whatever space is available. The falx is present. You have a normal posterior fossa. There's high morbidity, mortality. Possible cause for this is going to be some type of intrauterine infarction, secondary to internal carotid artery occlusion or malformation. So the ones that I've seen with the hydranencephaly, a lot of the moms have been addicted to drugs, and mainly the ones we saw this with was cocaine, and they would have these massive infarcts and just basically clot off the blood supply to the cerebrum. So hydranencephaly, so we have all this supratentorial space, all this fluid. So these, of course, these babies do not do well. And then we can move on to holoprosencephaly. It's a developmental brain disorder. You can have impaired or incomplete cleavage of the embryonic forebrain. You have abnormal midface development. So there's 3 classifications of the holoprosencephaly. So alobar is the holoprosencephaly is the most severe. Brain does not separate in the hemispheres, so you have a monoventricle. So you have interruption of the falx. You have one monoventricle, and that ventricle can have many different shapes. The remaining brain has 3 appearances, so pancake, cup, and ball. Those are the different main shapes that we see of this monoventricle. You have fused thalmi. You have absent corpus callosum. You may have a proboscis. We'll go over that. And then you have facial anomalies. So high association of facial abnormalities with the holoprosencephaly. So cyclopia, hypotalorism, and then median clefts. So midline clefts, closely spaced orbits, and trisomy 13 is the most commonly associated chromosome or aneuploidy with this type of brain abnormality. So you have a monoventricular system. And this is what it looks like. So we have our fused thalmi. We don't see any third ventricle there. And this whole ventricle just all communicates with each other. So here's that posterior fossa. Look, there's the thalmi and the peduncles. But this little cup-shaped monoventricle crossing. And there's the little thalmi, so fused thalmi. Look at the head shape, too. Look at how round that is. Remember we were talking about just looking at the shape of the head? That may be your first clue that something is going on with the brain structurally inside, is just by looking at the shape. Then we have semi-lobar holoprosencephaly. So that's less severe. You have incomplete anterior interhemispheric fissure. The thalmi may be completely or partially fused, so again, not as severe as the alobar. You have abnormal corpus callosum. And so a lot of the ones that we see are going to be along the anterior horns. We see this communication with the anterior horns, so it doesn't completely divide. Thalmi normal or partially fused. And then the other thing we can see with this that we can't differentiate on ultrasound yet is septo-optic dysplasia. So the lobar holopro and the septo-optic dysplasia may be the ones that we cannot tell on ultrasound. So again, the anterior horns of the ventricles are fused with a flat or squared off appearance. Some authors consider this to be one of the more mild versions of holoprosencephaly. And MRI is our best way of trying to distinguish it. Anything with the brain that we suspect on fetal ultrasound, we usually will forward on for MRI for confirmation. They're just better at it right now. So the septo-optic dysplasia, looking at our axial view, first thing we notice is we have the columns of the fornix here, but we don't have a cavum septum pellucidum. And then when we magnify up, we can see this fusion of the anterior horns. So they're flat or squared off. So normally on that coronal view, this is what we should see, is we should see the cavum septum pellucidum with the anterior horns, and this one was the septo-optic dysplasia. So another term for the septo-optic dysplasia would be the semi-lobar holoprosencephaly. So your schizencephaly is actually a clefting in the brain. So defect of the brain parenchyma extending from the inner table of the skull to the ventricles. So you have a clefting of the gray matter. It can be unilateral or bilateral. It's fluid-filled irregularities, spaces within the cerebral hemispheres. It may have absence of the cavum septum pellucidum. And a couple cases that I've had is they've been referred for hydrocephalus or ventriculomegaly. And what they didn't do was follow it out through the brain. I mean, look at this cleft here. This one, this whole area here was clefted out. And again, we're getting some artifact here from the skull. But you can see how this all communicates out through the cerebrum, out into the cerebral spinal space. So it's a clefting of the brain is your schizencephaly. So then with the MR, you can see this with the MRI. Look at this cleft.